Good afternoon, everyone, and thank you all for taking the time to join us today for our 6th event in our NIH and Medical Research COVID-19 series. I'm Erin Morton, Executive Director of the Coalition for Health Funding. Before we begin, I want to go over a couple of housekeeping items. Because we're using Zoom's webinar platform today, all audience members are muted throughout the discussion, but we will be taking questions at the end. To ask your question, please type it in using the Q&A function. You can start submitting questions now and throughout the presentation. We just ask that when you submit a question, please include your name and the full name of your organization or congressional office. I'd like to note that today's briefing is not open to members of the press. So if you've joined us inadvertently, we appreciate your interest, but would kindly ask that you disconnect at this time, and we'd be happy to follow up with you separately. The Coalition for Health Funding is pleased to be co-hosting this event with the Ad Hoc Group for Medical Research. As you know, NIH-supported medical research across the country is a key tool in battling COVID-19 and its wide-ranging effects. Our organizations partnered on this series to give both advocates and congressional staff an opportunity to hear from the directors of NIH's individual institutes and centers about how research to date and ongoing work can inform our response to the pandemic, as well as the impact COVID-19 is having on existing research across the agency's broad portfolio. We have 2 moderators for today's briefing: Mary Jo Hoeksema, Director of Government and Public Affairs at the Population Association of America, an Ad Hoc Group for Medical Research Steering Committee member, will moderate our Q&A. And to introduce our speaker for today's briefing, I'm going to turn things over to Don Hoppert, Director of Government Relations at the American Public Health Association and Coalition for Health Funding board member. Don, over to you.
Thank you, Erin. Coalition for Health Funding and the Ad Hoc Group are pleased to welcome Dr. Richard Hodes, Director of the National Institute on Aging, to our 7th event in this series. A leading researcher in the field of immunology, Dr. Hodes has served as the NIA director since 1993. Under Dr. Hodes' direction, the NIA leads the federal effort supporting and conducting research on the biological, clinical, behavioral, and social aspects of aging. He has devoted his tenure to the development of a strong, diverse, and balanced research program, which has led to innovative ways to conduct research, share data, and translate findings into practice. Dr. Hodes also directs the federal effort to find effective ways to treat or prevent Alzheimer's disease. Through cutting-edge research conducted and supported by the NIA, often in collaboration across institutes at the NIH, he has helped revolutionize the way we think about Alzheimer's disease and related dementias. Furthermore, Dr. Hodes' research laboratory in the National Cancer Institute focuses on the cellular and molecular mechanisms that regulate the immune response. A graduate of Yale University, Dr. Hodes received his medical degree from Harvard Medical School. He is a diplomat of the American Board of Internal Medicine, a member of the Dana Alliance for Brain Initiatives, a fellow of the American Association for the Advancement of Science, and a member of the National Academy of Medicine at the National Academies of Sciences, Engineering, and Medicine. With that, I will turn it over to you, Dr. Hodes, to give an overview of NIA's current activities. And when you're finished with your presentation, Mary Jo will open it up to our audience for any questions they might have. So Dr. Hodes, over to you.
Thank you, Don. Thank you, Mary Jo. Thank you all of us who've joined. Appreciate the opportunity to speak with you about some of the activities of the National Institute on Aging in particular, as they have been manifest during this past year and the influence of COVID-19. And what I'll be stressing when I talk about some of our activities is not only the relevance of aging and the mission of the Institute to the pandemic, but the ways in which the infrastructure and the research preparedness has allowed us to move into COVID-19 in a way that couldn't have happened without that infrastructure and resources. The next slide, please. This is just a reminder outline for all of you about the mission of NIA. It ranges from the conduct of a broad spectrum of research from the molecular, biologic, clinical, behavioral, to the fostering of training and career development to create a present and future workforce in that area, both inspired and diverse, providing the resources needed to carry out that research, and then finally disseminating the results of that research to the public and to the public health good. The next slide, please. So as I said, I'll be talking about a few examples of research findings and particularly try to note for you how these findings have come to be accessible in the course of research that NIA supports and carries out. So as you all know, I think for the risk factors involved in COVID-19, aging is a prominent one. That is, advancing age in adults is associated with a higher risk of serious infection, hospitalization, and sadly death. What is illustrated here is a result of some of our ongoing infrastructure in a way it allowed us to look at the impact of risk factors on outcomes in addition to age for COVID-19. So these are the risk factors that show interaction of age with education, with income, and with race and ethnicity. And you can see that for each of these sets of three graphs, the colors illustrate three age ranges from 25 to 44, 45 to 64, and then over 65. And you can see, looking at the left first at education, that less than high school education or less associated at all ages with a greater likelihood of having three of the demonstrated risk factors for serious consequences of COVID-19. Those with college or higher are protected across all ages with a lower incidence. If you look at income, similarly, in particular, the bottom quartile has a much increased incidence of those risk factors for serious outcomes from COVID compared to the top quartile for income. And then interesting, if you look at the interaction of age with race and ethnicity, again, age always an important factor. But here you can see that compared to the white non-Hispanic populations, that Black African Americans at all ages have a higher probability of these risk factors. Hispanics in this analysis are similar to whites. So the interaction between age and other risk factors for outcomes of COVID-19 has come from our ongoing surveys of our populations that were quickly adapted, in this case, to studying the impacts on COVID-19 during this pandemic. And the next slide, please. So in addition to the disease itself, there are interesting impacts on the mental state of those during the pandemic, even not necessarily affected by the infection directly itself. So this is an interesting study that was carrying out where the infrastructure, as I mentioned, is the NIA-funded Understanding America Study Survey. This is an all online survey that's been carried out for some years now. And because it's online, it allows us in a nationally representative population to add questions to survey and have rapid answers to ongoing changes, including that for COVID-19. So this particular slide illustrates the increase in COVID-19 associated discrimination and mental distress during some of the early months of the coronavirus outbreak. So distress caused by coronavirus pandemic, perceived discrimination, was more commonly experienced in racial and ethnic minorities, in immigrants, in those who were wearing face masks, and those who had symptoms associated in addition with an increased mental distress. And this survey continues, so month by month, we have updates of these kinds of data, and we're able to ask new questions and survey then in near real time what's happening, I stress again, in a representative population of the United States with the appropriate distribution of age, racial, and ethnic parameters. Next slide, please. So if we look at the interaction of advancing age with sex, gender, and the likelihood of death among hospitalized COVID-19 patients, this is a study that was carried out where the infrastructure was the Roybal Centers for Translational Research. Again, an NIH-supported centers program that in an ongoing way surveys important happenings in the population of older adults and is capable of adapting to circumstances. So here we're looking at, of those individuals who are already hospitalized, what the likelihood is of death. And you can see as a function of age, as one comes down from the less than 20 through 90 plus, a dramatic increase, as you saw in a previous slide, as a function of age for death and risk of death for those who are already hospitalized. And similarly, that when one looks at male versus female at all ages, the risk of death is higher for male. So an extraordinary dependence upon age, the comorbidities and risk factors that go with it, with an important biologic and clinical identification, as well as a difference in male-female susceptibility to the outcomes of COVID infection. Next slide, please. Another of the infrastructures that's been in place now with NIA funding is the NIA Impact Collaboratory, designed to address dementia care by having in place resources that have direct contact with large numbers of older individuals living in a variety of healthcare settings, including those which are institutionalized. And within this trial, one has already then relationships with individuals that can be turned to the capacity for clinical trials or for conducting new pilots to work into this area of research. So in this case, primary purpose, dementia care, but again, an infrastructure that's allowed us to have contacts with large numbers of institutions. And the next slide, you can see an example of what was done. So the course early on of immunization, vaccination for COVID-19. So this is late December to January 1st. There was a lot of concern. There's this new vaccine, a new type of vaccine that hadn't yet been exposed, the RNA vaccines from Pfizer and Moderna. And so this was a study quickly done with some 284 nursing facilities used by CDC criteria for looking at adverse effects. And what is illustrated here is that the unvaccinated versus those that received a first dose had no difference in mortality in these first days. So this is not a measure of protection from the vaccinations, which is clear, but to illustrate there were no short-term adverse effects. So within days, we were able to turn around and have this reassurance and efforts to go forward with our vaccination protocol. Next slide, please. Now, clinical trials have been ongoing prior to COVID and had been affected in profound ways by the pandemic itself. I'll just illustrate for you here some of the ways in which we have attempted to pivot, adapt to the COVID-19 circumstance, and in some ways adapt and parameters that are going to serve us not just during the pandemic, but are likely to have a longer lived advantage. So for example, important trials of exercise for various outcomes are now using virtual coaching and fitness training, which were well into the population already, now adapted in these settings of research. And again, an example of those which are likely to facilitate the ability to reach multiple and diverse populations even beyond the COVID-19 pandemic and carry out research on many such interventions. Trials with intravenous infusions of medication. Now there's more of a challenge. Can't do that by computer, but we can do it by moving to in-home infusions and having infusion teams move into the homes of those who are the participants in these clinical trials. And this is working extremely well. And again, points to an adaptation that may decrease the burden on study participants, the costs, and facilitate research beyond the domains of the pandemic. And finally, in a broad statement, many of the trials have shifted to remote monitoring and screening of patients for cognitive function, for physical well-being, for a variety of endpoints that are being more increasingly accessible through remote means. And as I said, by summary at the bottom there, a number of these will remain long after trial sites reopen potentially for in-person studies, but I think be finding reduced barriers to participation in studies and to be able to carry out studies in broader populations with this new flexibility. The next slide, please. So with that introduction kept brief, because I'd like to have the opportunity here to hear from you and address questions you have, let me stop, pause, and now open up to questions from all of you.
Thank you, Dr. Hodes. That was very interesting. And I just want to remind all of the participants that they can submit their questions anytime by using the Q&A function. Just please post your name and the name of your organization so we can identify you properly for Dr. Hodes and the rest of the group. While we wait for some questions to come in, Dr. Hodes, if I could ask you something that's been in the news a lot this week, of course, has been NIH's efforts to address the long-term effects of COVID-19. Wondering what sort of NIA's contribution to this effort is or will be, and also if you could speak to how the Institute plans to address not just the long-term health effects of COVID, but also the social, behavioral, and economic health impacts of COVID-19.
Thank you, Mary Jo. Great question. Let me say broadly that NIA has been a participant along with many of the institutes at NIH in a variety of NIH-wide efforts. One family of them are the RADx studies, RADx having to do with rapid diagnosis, where there's been a focus on looking at accessibility to testing and contact tracing in diverse populations, a real challenge. So NIA, myself, with NIH MHD and El Seo, Professor Stable have taken the lead with many institutes involved there as we look for new technologies and apply them. This now takes a transition as we come to vaccines and looking to find how to assess accessibility in many dimensions to vaccine and development. So we're working through this in new and continued partnerships as well. This involves studies of the biology of the long-term consequences of COVID-19 infection, as well as the, as you've alluded to, behavioral, social, and economic implications. A new effort just beginning in an organized way called PASK, looking at the consequences long-term of infection, involves participation of NIA, again, along with other institutes, and we'll be putting together and recruiting cohorts of individuals who either have had infection and now will be studied prospectively for long-term consequences, or those who are at risk, so we can look at the identification of what risk factors even prior to infection predispose to long-term outcomes. These are already, as you know, manifold, involve apparent brain and neurologic abnormalities, those involving senses, musculoskeletal, truly systemic, and interesting, Mary Jo, a lot of the acute and even chronic consequences of COVID-19 do have some similarities and parallels to the manifold changes that occur and predispose with conditions with aging. So excess of inflammatory responses that can be counterproductive and be responsible for some of the consequences of aging, age-related conditions are a primary feature as well in COVID-19 acutely and potentially long-term post-infection as well. So we're finding, as I think is a generalized case for other institutes as well, that a lot of the mainstream activities in which we're engaged have a strong overlap with phenomena of COVID-19, all of which then we hope are going to address not just protection from acute, but as you're alluding to, understanding and treating and protecting these long-term consequences, which tragically already appear to be involving months and years post-infection for a substantial portion of those people who are infected.
Thank you. That's a very thorough answer. Appreciate that, Dr. Hodes. We've had a question come in while you were speaking from Pat Kober with the American Psychological Association. Pat says that NIA has been a leader at NIH studying various aspects of racism. How do you see the current initiative on structural racism as supplementing the efforts that your institute, as well as others, have already begun?
Hi, Pat, and thank you for the question. Yes, this has indeed been a long-term priority for NIA and its involvement. Interestingly, the NIMHD director, El Seo, who's a great partner of ours, had his NIH beginnings, as you may know, and a council member of the NIA Advisory Council, and our own plan for looking at health disparities and structural racism, therefore has real parallels and strengths with him and with the rest of NIH. So taking the strengths of NIA research, including the behavioral social research, our tracking infrastructure for diverse populations has always been a priority, and now allows us to look at the impact of policies and their modification on the parameters we can follow in populations that are diverse. NIA shares with a lot of institutes a challenge not yet adequately met, among others, in recruiting into both its workforce of investigators and into participants in clinical research and studies, a diverse population. A complex consequence of structural aspects of our population and society, which I think we've made progress, but we have a long way to go, and where the acceleration is now happening. So our efforts include those to recruit into our own workforce and the investigators whom we fund, a diversity that's important to getting the right spectrum of insights and inputs into creative research, as well as doing even better at recruiting into research participant populations, those that have the full age span, because this has been a place where older individuals have been underrepresented, as well as one which is more representative of the populations at risk for the conditions with which older adults in particular, but across the whole lifespan for that matter, are afflicted. So as you may know, the deputy director of NIA, Marie Bernard, is now also working in her overly committed time to being the acting director of the Office of Workforce Diversity at NIH, and has been a co-chair, therefore, in the Unite effort overall as we go forward. So through our own priority and through the remarkable efforts of Marie and her new additional responsibilities, we are enthusiastic, excited about the challenge and the commitment across NIH, and for that matter, it appears of a spectrum of agencies across federal government now uniting, if you will, in this research. So our efforts are not new, but they will be leveraged, they'll be enhanced, and they will evolve the spectrum once again of the talents which our workforce brings, not just clinical, biologic, but also in the behavioral and social research aspect, and which Pat is well aware of.
Yes, as am I. And I guess you'll also be hearing a lot from other stakeholders. There is an RFI out for requesting comments from the community. So I know a number of organizations will be giving you feedback, and looking forward to seeing how NIH incorporates our feedback moving forward with this initiative. Richard Turman, ACT for NIH, says to tell you rather, thanks Dr. Hodes for all you do. His question is, NIH modified some of its operations during the pandemic to be able to move so quickly. Which of these changes, if any, do you see NIH/NIA making permanent in order to move faster on everything, not just COVID-19 related research?
So hello, Richard, good to hear from you again. Yes, so the changes made to adapt to the pandemic were many, some transient and others likely to be long lasting. So for example, when it was necessary to quickly move to fund research and supplement existing research in the time frame of weeks and months in order to understand what was happening and address it, we modified some of the policies for peer review. I think we maintained high standards, but rather than the usual application study section process, we had authorities under the supplemental appropriations to review things more rapidly. This has served us well, but has evolved now as we have become more up to speed and more of a steady state in addressing the problem, to a dependence upon more conventional peer review mechanisms. That's an example of an adaptation that I think served importantly in pivoting to a longer term approach, which could rely on the well-established mechanisms. What we have certainly learned more of than ever before, in part I alluded to in some of the presentation of slides, the way in which we carry out research. So our ability to work remotely, to assess and even administer treatments remotely is something that we will be taking advantage of long term. Data. We have been at the NIH level for some years now, been emphasizing data sharing, but now this has moved to a whole new order of magnitude in which we need to have rapid turnaround of data from real time that has been brought from multiple studies supported by multiple institutes and centers, that both protects confidentiality, which is important to participants, but allows rapid response. These are the types of infrastructure that are in place now for NIA, across NIH, that I think are going to reside and be long-term. So data management, the ability to quickly adapt to circumstances by modifying review and funding are among those.
Wonderful. I have a question from Kimberly Sorota with the American Urological Association. She says, Dr. Hodes, you touched on the adaptation of clinical trials to at-home infusions and remote monitoring. There is concern over older adults not getting their yearly preventative screenings, such as PSA screenings. Do you have an idea of what the long-term outcomes would be for this? Do you think we are going to see an increase in cases and mortality rates long-term? And how is the NIA looking at access to telemedicine post-COVID?
Yeah, Kimberly, it's a great question. I think that this is a concern many of us have. So among the kinds of research data that give us an idea of the scope of this problem have been studies which have looked at, again, across racial, ethnic groups and age, at the proportion of individuals who have delayed either routine care or acute care. And the finding is that in both of those categories, there has been a delay in a number of populations, and perhaps most disturbing is that in the most disadvantaged populations, including Black African Americans, Hispanic, for example, who are at risk for many chronic diseases, it is in those populations, probably reflecting many socioeconomic and other variables, where the decrease in routine screening has occurred. Now, there'll be some lag before we see this reflected, I hope not tragically, in the outcomes of decreased screening, meaning later detection and less treatable stages of disease, ranging from cancers to cardiovascular disease, diabetes, and so on. So yes, the ability to institute remote means of establishing or maintaining screening and relationship between care providers and individuals is an object of ongoing research. The NIH mission will be to experiment, as we're doing, with the feasibility and the effectiveness of these kinds of remote interventions, then of reporting those results and transitioning, if you will, then to the responsibility for the healthcare system and providers armed with the results of NIH-funded research to make those changes necessary in practice. So this is part, I think, of a long and effective partnership where NIH research informs policymakers in practice effectively. And this is another acute example of that. So the research is happening to point to the problems, and we'll do all we can to inform now the policymakers and the providers of care so they can take advantage of these research demonstrations.
Dr. Hodes, Heidi Davis from Ochsner Clinic Foundation writes, where can we learn more about the COVID-driven data management initiatives you just mentioned?
Let me offer again to follow up. We'll provide the links and examples of these, and Mary Jo, you and others can then pass them on.
Happy to. We're getting close to the end of our time with you, but I would be remiss, I think, if we didn't give you a chance to reflect more broadly on your institute's research portfolio. It's one of the broadest of the NIH Institutes and Centers, and I think something that's on the minds of a lot of us who follow your institute very closely is how the pandemic you feel is affecting or influencing the many strategic priorities that the NIA has.
Thank you, Mary Jo. So I would be remiss in not taking advantage of this opportunity to thank those in our audience who importantly have supported NIH broadly and NIA. The growth in NIH, in particular NIA's appropriation and funding, has made possible a lot of the infrastructure and the research that we're talking about. So thank you for the opportunity to say that to those of you who are participating here. The increased emphasis on research in older men and women follows, of course, the demographics. What has been particularly gratifying for me is that this growth in research has been one we could share across the institutes at NIH and all of NIH. It's clear that the NIA mandate overlaps strongly with many other institutes. This is reflected in a number of ways, but for example, with the increase in funding for Alzheimer's-related dementias over these past years, we have in substantial measure, though the appropriation comes to NIA, used this to fund research by essentially all of the other institutes at NIH. So in the range of hundreds of millions of dollars to support relevant research that is in the domains of other institutes and centers. Similarly, the research that we carry out following the trajectory of older populations through epidemiologic and population studies has been an infrastructure for the use of many of the other institutes. So excitement for me includes the fact that we are able to play an important role in the NIH mandate to address health and well-being across a diverse population and do so with the full partnerships of the institutes and centers and certainly with NIH leadership as well. So it's an exciting time. COVID has challenged us. I do have to say that the staff at NIA and NIH has been remarkable in the efforts they've been putting in, working harder than ever. You know, it's not as though the pandemic has meant that there was less work to do. It's in fact been more, and boy, have staff risen to, as I'm sure have been all of you as well. So I thank you for the opportunity to be a part of NIA and NIH through the pandemic and with the gratifying support from all of you.
Well, thank you. And thank you for your time. And I think that's all the time we have for questions. I will turn it back over then to Erin to close us out.
Thanks, Mary Jo. And thank you so much, Dr. Hodes, for your remarks today and for taking the time to talk to everybody. We really appreciate you joining us and appreciate the work that you all are doing. And a special thank you as well to you, Mary Jo, and to Don for taking the time to help us lead today's event. We did record today's webinar and it will be posted on both the CHF and Ad Hoc website. So if you missed any part of it or want to share it with others, it will be available in a few days. Thank you again to all our speakers and have a good rest of your day.